Hi, this is Rachael Marks.
And this is Charlotte Raisbeck.
And I'm Jordan Roycroft, and we'll be doing our presentation on coronary artery disease. Meet Joe. Joe Kenworth is a 57-year-old male. He's 165 centimetres tall and 98 kilos. He has a history of coronary artery disease and hypertension and is currently presenting with an MI. He smokes 1 pack of cigarettes a day and eats a diet high in cholesterol. Joe is a truck driver, and so he spends the majority of his time on the road and therefore lives a sedentary lifestyle. He has a family history of type 2 diabetes mellitus, and his father died of a stroke.
Clinical manifestations. A common symptom of coronary artery disease can present with stable or unstable angina. Angina could present with chest tightness or pressure on or around the chest. In men, pain can radiate to the jaw, shoulders, neck, back, or down the arms. Stable angina often happens at predictable times. For example, when someone is exerting themselves through exercise or when someone is stressed. Stable angina will often subside with rest. Unstable angina occurs for no reason and can come on at any time. The pain generally doesn't go away with rest, and medications are usually required to assist with angina, including GTN spray. This sublingual medication is used to dilate blood vessels to allow maximum blood flow to relieve the symptoms of angina. If the GTN spray doesn't work, it can be an indication of a myocardial infarction or serious complications that need to be addressed by emergency services. Coronary artery disease often can present without symptoms. Signs and symptoms occur when someone is experiencing angina or having a myocardial infarction. The symptoms of angina can be an indication that someone is having or may have a myocardial infarction. These symptoms may include chest pain, radiating or not, sweaty or clammy skin, shortness of breath, dizziness, nausea and vomiting, palpitations, indigestion or heartburn, and anxiety. Clinical signs and symptoms may include a low oxygen saturation and capillary refill, high blood pressure, high heart rate, increased work of breathing and high respiratory rate, changes on an ECG including ST elevation, his recent past history, and recent pathology results.
Pathophysiology of coronary artery disease, which will be referred to as CAD, with reference to the case of Joe Kenworth. Coronary artery disease refers to when coronary arteries become afflicted by atherosclerosis. Ambrose and Singh, 2017, describe atherosclerosis as a low-grade inflammatory state of the intima or inner lining of medium-sized arteries. Both CAD and atherosclerosis are considered to be slow-progressing diseases, as they typically develop over an extended period of time as opposed to having a sudden acute onset. It is suggested that the process of atherosclerosis and subsequent acute complications associated with CAD are accelerated by several modifiable and non-modifiable risk factors. With reference to the case of Mr. Kenworth, the non-modifiable risk factors present are that he is male and that there is a family history of cardiovascular disease. Studies suggest that CAD has a greater prevalence in men compared to women. Hajar, 2017. Hajar additionally lists high blood pressure, high blood cholesterol levels, smoking, diabetes, obesity, lack of physical exercise, and an unhealthy diet as modifiable risk factors associated with CAD. Mr. Kenworth's lifestyle habits are therefore suggested to be the primary attributing factors relating to his current presentation. Atherosclerosis occurs due to a buildup of low-density lipoproteins, or LDL cholesterol, on the arterial wall, which becomes plaque. Raffian-Kappai, Satorki, Doody, Baradaran, Nasri-Dew, 2014. Due to Mr. Kenworth's high cholesterol diet, it is suggested this process may have been accelerated as a result. His smoking is also likely to have depleted any high-density lipoproteins, or HDLs, he had, while simultaneously increasing LDLs, leading to further plaque buildup. Over time, the plaque would have become bigger and potentially restricted coronary blood flow. Coronary artery disease can either remain asymptomatic or become symptomatic. In the case of Mr. Kenworth, it is suggested that a section of plaque within the anterior descending artery, left circumflex artery, or right coronary artery has ruptured. As a result, the red blood cells or platelets clump together in order to prevent the spread of LDLs through the bloodstream. This is known as coronary thrombosis. As a result, Mr. Kenworth has developed an acute coronary artery syndrome, CAS, in this case, ST segment elevation myocardial infarction, Ambrose and Singh, 2017, all of which attributing to the patient's change in CAD status from being asymptomatic with no myocardial ischemia to his current deterioration and subsequent presentation.
Nursing interventions. Monitoring physical observations. Control of blood pressure. Making sure that Mr. Kenworth has his hypertension well managed is a vital goal needed to help prevent further injury related to his coronary artery disease. As previously mentioned, hypertension is a major risk factor for the progression of coronary artery disease. As the nurse looking after Mr. Kenworth, having constant, accurate blood pressure monitoring will help to guide the doctor in appropriate pharmacological interventions. This will help to assess if current treatments and medications are providing a positive benefit for Mr. Kenworth and his medical treatment. Having coronary artery disease and hypertension heightens the risk of kidney disease due to the excessive pressure and narrowing of the arteries of the kidneys. Pathology interpretation. Having consistent monitoring of Mr. Kenworth's pathology results, including his urea creatinine and estimated glomerular filtration rate, will monitor his kidney function. This will enable his medical team to monitor his kidneys and see if they have been affected by his coronary artery disease and his hypertension. The importance of checking Mr. Kenworth's troponin levels is vital in establishing healthy heart function, considering Mr. Kenworth's recent hospital admission and relevant medical history. As Mr. Kenworth's nurse, picking up high levels of troponin through regular pathology tests could initiate immediate action to prevent heart muscle death. A standard lipid profile measuring Mr. Kenworth's level of high and low density cholesterol along with triglycerides will monitor the progression of how his treatments are working, how the current treatments are working. Baseline ECG. Having a baseline ECG on admission is important as a referencing point. It allows the nurse caring for Mr. Kenworth to have critical data to compare to, should he present with any further symptoms of a myocardial infarction or any other conditions or symptoms relating to his medical presentation. The nurse may have to continually monitor Mr. Kenworth via telemetry to observe and action potential harmful ECG changes. For example, peak T waves or ST elevation. His current health and prevention of the progression of his disease is one of the most important aspects of the care he receives. Mr. Kenworth needs to be educated on the signs and symptoms for problems associated with his disease, along with how to manage each situation, including when to seek help and when to use particular medications such as his GTN spray. He should also be advised to take his own blood pressure while at home and be educated to identify safe and abnormal parameters. The significance of not making changes and following medical advice should be discussed, as well as the interventions regarding coronary artery disease, including invasive procedures such as coronary angiograms, used to unblock arteries and restore blood flow. Mr. Kenworth needs to be fully aware of how his disease will directly affect his future health, should he not change his current modifiable lifestyle. Mr. Kenworth needs to be educated on improving his diet, including limiting high saturated fatty foods and sugary drinks, limiting his smoking and alcohol intake, committing to some sort of daily exercise, and reducing his overall BMI. Involving allied health. Making sure that Mr. Kenworth is set up whilst in hospital and for when he is discharged home with referrals to see allied health professionals that will support Mr. Kenworth in positively changing his current health challenges. A dietitian to help him change his diet along with educating him on the prevention of diabetes mellitus through diet control. An exercise physiotherapist to aid in providing Mr. Kenworth with appropriate, safe exercise to get him started, and making sure that Mr. Kenworth is utilising his GP to monitor his progression and as a starting point for any other concerns for his future health and management of his conditions.
Coronary artery disease complications. Coronary artery disease is the most common type of heart disease. As mentioned, the condition causes the blood vessels in which supply the heart with oxygen to become narrow and harden due to the buildup of cholesterol and plaque. As Mr. Kenworth is suffering from CAD, many complications can arise due to the disease's interference with the supply of oxygen to the heart due to the blocked arteries. If CAD is unnoticed or untreated, the severity of the disease worsens, which can lead to the heart not being able to perform to its full potential. It may become irregular, might cause angina, may lead the heart to failure, or even completely block its function, causing a myocardial infarction, as seen in Mr. Kenworth's current presentation. The risk of heart arrhythmias in CAD patients is elevated, as the blocked arteries limit the amount of oxygen that enters the heart. If the heart tissues do not receive enough oxygen, the heart rate and rhythm may become damaged. This causes the heart to develop an irregular heart rhythm, either becoming faster or slower. This process is called atrial fibrillation. The sensation of the heart pounding, fatigue or dizziness, chest pain and weakness are all indications of AF, states Dan, G.A. and Dobrev, D. 2018. Angina is another possible complication with CAD, as it is the feeling of pressure, squeezing, heaviness, tightening, burning or aching across the chest region. Heart arrhythmias can impair the functioning of the pumping action of the heart, which can lead the heart to failure. Heart failure in CAD patients can vary depending on which part of the heart is affected. If the right side of the heart is affected, blood can build up in the veins in which carry blood to the organs, tissues and back to the heart. This build-up increases the pressure within the veins, which can then be pushed into the surrounding tissues. This is when edema occurs, usually in the legs or in extreme cases in the abdomen or liver. If the left side of the heart is affected, the blood vessels that transport blood away from the lungs start to accumulate blood, reducing its normal functioning of transporting oxygen. This usually causes shortness of breath as the fluid buildup reduces the normal movement of oxygen in the lungs. Kim W. and Kim E.J. 2018 state that the severity of heart failure in CAD patients can adjust individually. Some patients may not have any symptoms and others may be predominantly affected. Heart failure typically develops several other conditions or issues as a failing heart cannot provide sufficient blood or oxygen throughout the body. When organ perfusion is compromised, heart failure may lead to potential cerebral ischemia and stroke. A 2019 study by Feldman states that when the heart muscle does not have enough blood or oxygen, the formation of blood clots can develop from the plaque in the coronary arteries, causing a myocardial infarction. The blockage completely stops the heart from receiving oxygen. Therefore, if left untreated for too long, the heart muscles can die, making the situation life-threatening. Mr. Kenworth would have experienced the feelings of chest discomfort, dizziness, shortness of breath. He may have become paler in the face, become sweaty, and had general discomfort at the time of his arrest. The severity of a MI is extreme as it can lead the heart to stop altogether. Therefore, the risk of death is high. CAD is one of the leading causes of death universally and one of the most common chronic illnesses in the developing world, states Kanzaswamy and Zuo 2018.
The following are the NSQHS standards relating to the case of Joe Kenworth. 2.3 Healthcare Rights and Informed Consent. As Joe is a long-haul trucker, NSQHS Standard 2.3b, easily accessible for patients, carers, families and consumers, must be adhered to, as he is unlikely to be in a fixed location. However, Joe is still entitled to access healthcare on the road. Action 2.7 states, the Health Service Organisation supports the workforce to inform partnerships with patients and carers so that patients can be actively involved in their own care. As there are multiple complications in Joe's health, studies suggest that he should be as involved in his own care as possible in order to improve his outcome. 4.1 Integrating clinical governance. Due to health complications, Joe is more likely to be on multiple medications. Action 4.1 Safety and quality systems support clinicians in the safe and effective use of medicines and reduce medicine-related risk. Managing risks associated with medication management. 4.2 Applying quality improvement systems. A medication review in the hospital would help reduce the above risks. 4.3 Partnering with consumers. Joe should be linked in with a pharmacy in order to get a Webster pack. Action 5.2b Implementing strategies to improve the outcomes from comprehensive care and associated processes. Links into the interdisciplinary team to improve patient outcomes as per 5.4, 5.5 and 5.6. 5.4a Provide care to patients in the setting that best meets their clinical needs. B. Ensure timely referral of patients with specialist healthcare needs to relevant services. This action will ensure the team caring for Joe consider his lifestyle. Example, travelling when making referrals and setting up his care plan. 5.5a Support multidisciplinary collaboration and teamwork. 6.1b Managing risks associated with clinical communication, as Joe would be on the road a lot. E-health records will reduce the risk of polypharmacy. 6.3c Shared decision making is implemented, as Joe would see multiple doctors and therefore communication through e-health records should be maintained. 8.1b Managing risks associated with recognizing and responding to acute deterioration. 8.2b Implementing strategies to improve recognition and response systems. C. Reporting on effectiveness and outcomes of recognition and response systems. Before his current admission, Joe had a high risk of MI because of his extensive medical history. Was there already a plan in place? Will a new plan be integrated on discharge? And was his current plan effective when Joe deteriorated in this instance? Patients should be involved in all aspects of care as per all NSQHS standards.